bone implantation syndrome, sir. Bone implantation syndrome. Sir, bone cement implantation syndrome is a potentially fatal complication of orthopedic surgery involving pressurized bone cement. Bone cement implantation syndrome is characterized by hypoxia and hypotension, maybe with potential loss of consciousness occurring around the time of bone cementation. The most commonly affected patients, the risk factors for this bone cement implantation syndrome are increasing age, significant cardiopulmonary disease in the patient previously, and the usage of diuretics in patients, and also predominant in male sex patients. And bone cement implantation syndrome results in reduced arterial oxygenation, characterized by a combination of some clinical features. They are hypoxia, sudden loss of arterial pressure, that is systolic blood pressure decreases, and pulmonary hypertension, arrhythmias may occur, and the loss of consciousness can occur, and also cardiac arrest is the main complication. Bone cement implantation syndrome has a wide spectrum of severity. A majority of affected patients develop non-fulminant syndromes. Non-fulminant bone cement implantation syndrome is characterized by a significant but transient reduction in arterial oxygen saturation and systolic blood pressure in the peri-cementation period. A small proportion of the patients will develop fulminant effects of bone cement implantation syndrome, which are characterized by profound intraoperative cardiovascular changes, progressing to arrhythmia, shock, and cardiac arrest. The main pathophysiology is, the pathophysiology of bone cement implantation syndrome is not fully understood, but several mechanisms are proposed. One is embolic model. During surgical cementation process insertion, the cement is intentionally pressurized to force the cement into the interstitium of the bone so that it can form a firm bond. The implant can form a firm bond with the existing bone, ideally improving the bond between the cement and bone. The cement then expands in the spaces. It is the exothermic reaction, which it produces some heat, and also it expands in the bone interstitium, further pressurizing the air and medullary content, pressurizing the air in the medullary contents and other debris are forced into the circulation. The embolic contents include fat, bone marrow, the cement particles that we used, the polymethyl methacrylate cement, that's particles, some air, bone particles, and also aggregates of platelets and fibrin. When these debris embolize, they may reach the lungs, heart, or coronary circulation. It is hypothesized that showers of pulmonary emboli are the cause of characteristic hypoxia and right ventricular dysfunction in bone cement implantation syndrome, leading to hypotension. These physiological changes from embolization can be attributed to both the mechanical effect and the these emboli release histamine release, and hypersensitivity reaction can occur, and complement activation also, the cascade begins and provokes increased pulmonary vascular tone. The anaphylaxis and bone cement implantation syndrome share many same features, notably the significant increase in plasma histamine concentration. When the histamine concentration increases, it leads to increased C3A and C5A, the complement in blood levels. These are anaphylactide complements that are potential mediators of vasoconstriction and bronchoconstriction. Collectively, it is felt that mediators yield an increase in pulmonary vascular resistance due to the vasoconstriction caused by these complements and histamine, causing ventilation perfusion disturbances, leading to hypoxia and the right ventricular failure and cardiogenic shock. Management. It is the bone cement implantation syndrome should be managed collectively. Initially, the patients who are at risk should be identified. They are increasing age, significant cardiopulmonary disease previously, and diuretics and male sex patients. And the both surgical team and anesthetic team should be prepared, and each role should be categorized. Preoperative multidisciplinary discussion and planning should be done. Anesthetist should ensure that the patient has good cardiac output before the cement is inserted. And the frequency of measurement of blood pressure is decreased to 2.5 minutes, 2 to 2.5 minutes. The intraoperative roles for anesthetic team and surgical team are different. For anesthetic team, adequate hemodynamic optimization and preoperatively and intraoperatively, it should be done. And aim for the 20%, maximum for 20% decrease of the systolic blood pressure than the pre-induction value. Vasopressors should be kept ready in case of cardiovascular collapse, if at all it occurs. Confirm awareness that cement is about to be applied. We have to make aware that the cement is being applied to the team. Maintain vigilance for cardiorespiratory compromise. For the surgical team, they should inform the anesthetist prior to cement application. The femoral canal should be washed thoroughly and dried. After cement applied, the cement should be applied retrograde fashion, utilizing the suction catheter and intramedullary plug in the femoral shaft. Sometimes the hole is made in the femoral shaft so that the pressure that was building inside is relieved through that opening in the shaft. Avoiding excessive pressurization. The precautions that should be taken in order to decrease the intensity of this bone cement implantation syndrome, or to avoid the bone cement implantation syndrome. There are surgical techniques that have been identified as reducing the incidence of bone cement implantation syndrome. Alterations in surgical technique consists of changes to minimize the likelihood of cement embolization. Consideration of using uncemented process in high-risk patients. As anesthetic management of bone cement implantation syndrome is mainly supportive, once the decision has been made to proceed with the operation, surgical modifications are the main alterations which will affect the occurrence of bone cement implantation syndrome. The surgical techniques addressing bone cement implantation syndrome are lavage of femoral canal prior to cement insertion, high pressure, high volume, and pulsatile lavage. Pulsatile lavage should be done during the insertion of the cement. Brushing and drying of the intramedullary canal of the femoral shaft before cementation. Use of the suction catheter to depressurize the intramedullary canal. Utilizing a bone vacuum technique, that is mixing the cement in vacuum and using the retrograde cement introduction. Identification and treatment of bone cement implantation syndrome. Under general anesthesia, this bone cement implantation syndrome, when occurs, if the patient is in general anesthesia, the features will be different. And if the patient is in spinal anesthesia, we can assess the loss of consciousness, which was not possible in general anesthesia. So under general anesthesia, a significant drop in systolic pressure may indicate cardiovascular collapse, and a sudden drop in end tidal CO2 may indicate right heart failure, leading to catastrophic decrease in the cardiac output. In an awake patient under the regional anesthesia, early signs of bone cement implantation syndrome may include dyspnea, cough, and or altered sensorium. Cardiovascular collapse in the context of bone cement implantation syndrome should be viewed and treated as right ventricular failure. In general, early and aggressive resuscitation is the best for the treatment of bone cement implantation syndrome. Administration of 100% oxygen is first-line therapy. Invasive hemodynamic monitoring, if the patient is not on invasive monitoring, it should be established. Fluid resuscitation is done to maintain right ventricular preload, and inotropes to support ventricular contractility are recommended. Vasopressors such as phenylephrine and noradrenaline generally used, primarily causing peripheral vasoconstriction, increase aortic blood pressure, which in turn supports coronary artery blood flow and thus improves myocardial perfusion and contractility. Use of vasopressors and inotropes should be continued into the postoperative period as necessary under the management of intensive care unit. This bone cement implantation syndrome is transient, and within 24 hours, the physiology of the patient returns to normal. Within these 24 hours, we have to use the vasopressors and inotropes, and the patient should be taken care of in the postoperative period in the intensive care. Thanking you, sir. Hello, sir.
Yeah, Srikanth. How many cases? You said 2 cases, Jagdish?
Yes, sir. 2 cases, sir. Previously, 1 week back, a case just survived, sir. The case that was encountered in the last month, we couldn't save that patient, sir.
What is the main reason for lethal cause?
Sir, this fat embolism, we were expecting that it was fat embolism and bronchospasm, sir, because the patient that was encountered 1 month before was a known asthmatic patient, sir. Maybe this bronchoconstriction may have exaggerated her previous underlying illness that lead to there was no time for us to save the patient, sir. Even though we administered 100% oxygen and secured her airway, but we couldn't save that patient, sir. It was within 5 minutes.
Ventilator was not put, huh?
No, sir. We immediately have intubated and ventilated, sir. But within 5 minutes, within 5 minutes, sir. I mean, 3 to 4 minutes only. The patient, we lost the patient, sir.
When suddenly when you intubate, what is the first step you do?
Sir, we had % oxygen, sir, and we gave hydrocortisone, and we started vasopressor, sir, because the BP was completely below the, 60 to 50 systolic pressure. Sir, there is no arterial line, sir.
Did you put the arterial line?
No, sir. Invasive
Did you do
monitoring
ABG?
we have not done, sir. Yes, sir. We have done ABG, sir.
Yeah, what is the pH and what is the PCO2? What is the basic and electrolytes?
Sir, I couldn't remember, sir.
Then how do you know that's the cause? What you see? Unless the main reason is that at the condition, severe condition, acute condition, you are telling that embolism. Agreed.
Yes, sir.
There should be some reasons for it. Something to be assessed. No, hypoxia. Suddenly, when hypotension is there, not responding, you will see something in ABG. You can diagnose. No.
Yes, sir. Yes, sir. We have sent for ABG, sir, but values I didn't remember now, sir.
No, you didn't remember. That's okay. But now preparing for the class, no, you are preparing for the class. Sir. You must have seen at least the PPT you should have made. Already in that it will be available in the cell phone. Can you just check the ABG? Can you just let us know the ABG? Because we want to understand that people are not doing ABG as soon as the patient is arrested. They are only looking at ROSC or they are looking at patient whatever once improved. They are not trying to correct the baseline. They are not doing that.
Okay, sir. Okay, sir.
Can you tell me the ABG?
Sir, I will check one, sir, whether I have in my phone or not. 1 second, sir.
Because any ACLS, any advanced guidelines, immediately we should do. CPR is doing okay, but hope you have done CPR.
Yes, sir. We have done CPR, sir.
And then what could be the reason? Is it a false track of intubation? Do you think it is correct intubation?
It was correct intubation, sir.
How do you confirm? ETC what was there?
So ETC what was there, sir.
Okay.
But there was a, wheeze, sir. Bronchospasm is there, sir. We gave hydrocortisone.
So severe hypotension.
Severe hypotension, sir.
And that's what refractory hypotension.
Hello, sir.
Refractory
Yes,
shock
sir,
is
yes, sir.
there.
Sir, I couldn't get you, sir. Hello, sir.
You are telling it is
Hello,
a
sir.
refractory hypotension or refractory shock.
Refractory hypotension, sir. She was unconscious, but it was below 60, sir. Systolic BP were below 60. We started NORAD. I think it was shock only, sir.
Did you do CT scan?
No, sir. No, sir.
You have CT scan, no?
No, sir. The patient. We have CT scan, sir.
Then maybe massive bleed in the brain.
That was after bone implantation, no, sir. That's why we thought that it couldn't be due to hypertension. The patient was not hypertensive or diabetic, but she was only asthmatic.
Now, what is the previous reasons? What is the percentage of bone cement syndrome death rate in the world?
Sir, 0.5 to 1.7%, sir. Approximately. 1 second, sir.
Srikanth is not there on the line.
Sir, I'm there. Sir, 0.5 to 1.7 incidence of death rate. It's looking like pretty high. Or incidence of bone cement implantation, you're saying?
Incidence of bone cement implantation syndrome, sir.
Yeah.
Incidence of bone cement, and in that death is, after incidence of bone cement, death is only 1%. That is, that's what I've read.
Total anta Chaitanya percentage is 1%. Bone cement syndrome.
0.5 to 1.7%, sir.
Bone cement is 0.5 to 1.5, sir. But death due to bone cement is around 1%.
This is definitely a serious case. They have faced a death means. I will ask Kiran if the details are available in the MRD, sir. We'll ask them to do a case presentation sometime next time.
This is very important. We have to do a case presentation, Jagdish, because it's not that anything wrong happened, because this can be preventable for somebody else in the future to have a clear idea, because normally anything, it's intraoperative death, no?
Yes, sir.
Supposed to be. Maybe
yes, sir.
Patient might have died post-operative later on, all this, okay? Is Bashir is online? Bashir?
No, sir, he left, I think.
Okay, right. So normally this is a very serious case. We should actually have to have, all of us should know what exactly, not knowing the patient name, place name, but understanding the case report is important. I think Manjula can write the case also.
Ravan Prasad, sir, any experience? I think maximum I have seen hypotension, that too within like 20 to 30% of the baseline, sir.
నేను పోస్ట్ ఆప్ చనిపోవడం చూశాను, బట్ నాకు అది బోన్ సిమెంట్ లేదా కరెక్ట్ తెలియదు.
Of course, last 4-5 years లో పెద్దగా కేసులు చేయట్లేదు అండి, అది వేరే విషయం కానీ, but at least in my early 5 years I have seen maximum that much only. This is a very good case. అనుకోకూడదు కానీ it will be harsh, but death due to bone cement implantation, I will ask Kiran once, sir. He's busy
No.
today. So
Sir,
Is
are
at
there
the
any
records,
is there any protocol made now to prevent this happening, sir? Now, I mean, after this.
While you should reaming, it should not be done forcibly. High pressure reaming. Common is that.
ఈ బోన్ సిమెంట్ మెటీరియల్ కూడా కొంచెం మారినట్టు ఉంది కదా సార్. ఐ మీన్ లైక్ లాస్ట్ 4 years లైక్ దట్ కొంచెం డార్క్ గా అలా వస్తుంది. ప్రీవియస్లీ ఇట్ యూస్ టు బి ఏదో ఇంట్లో సున్నలాగా ఇట్ యూస్ టు బి ప్యూర్ వైట్. బట్
Name of the
PMMA material same ఉంది సార్. Polymethyl methacrylate. I have seen the composition also, but there is something it's like కొంచెం డార్కర్ షేడ్ ఉంది సార్ ఇప్పుడు లేటెస్ట్ సిమెంట్ అంతాను. It's more soft also. So hardening kuda it is taking time. And in my earliest RK lo unnappudu ABC lo early ga unnappudu it used to be immediately solidified. Now that is taking like 3 to 5 minutes like that to solidify, and also color is also a little bit dark. I had to do some research on it, what changed in the cement and all.
it is common in long bone fractures. And I don't remember exactly. It should be operated either very early or after 10 days or so. In between, if you operate, it is more common. I think so.
Sir, that is embolism.
అది ఫ్యాట్ ఎంబాలిజం
Bone
కదా సార్.
cement.
ఇప్పుడు టీకేఆర్ గురించి మాట్లాడుతున్నాం. నీ రీప్లేస్మెంట్ లో బోన్ సిమెంట్ ఇంప్లాంటేషన్ గురించి సార్. నాన్ సిమెంటెడ్ ఇంప్లాంట్స్ ఎనీవన్ హస్ యు?
విషయం ఏంటంటే ఒక చిన్న విషయం. జగదీష్,
ఎస్ సార్, చెప్పండి సార్.
కెన్ యు టెల్ మీ ద సర్జరీ టైమ్ అండ్ ద యాక్సిడెంట్ పోస్ట్ యాక్సిడెంట్ అనేది?
పోస్ట్ యాక్సిడెంట్ సార్.
యాక్సిడెంట్ డేటు సర్జరీ టైం చెప్తావా
సార్? అరౌండ్ 3 days సార్. బికాస్
నేను చెప్పేది అందుకోసమే. ఐఎమ్ థింకింగ్ ఇట్ ఈస్ నాట్ బికాస్ ఆఫ్ బోన్ సిమెంట్, ఇట్ ఈస్ బికాస్ ఆఫ్ పల్మనరీ ఎంబాలిజం. Because any day which is crossing 48 hours we have seen, and I think David is not here. We saved 2 patients, and when I think Chaitanya ఉన్నింది అప్పుడు unit 2 లో. Chaitanya, హలో
సార్, నేను లేను సార్.
ఎవరు? శారదా ఉన్నింది అప్పుడు. ఎవరో ఉన్నారు మన వాళ్ళే. వెంటనే ఇట్లా అరెస్ట్ అయిపోయింది, స్పైనల్ ఇచ్చాము, అరెస్ట్ అయిపోయింది చెప్తే వెళ్ళిపోయి మళ్ళీ ఎక్కువ చేసి డేవిడ్ వెంటనే వచ్చి బట్టలు మార్చుకొని వచ్చి ట్రాంబులెన్స్ చేసి కార్డియాలజిస్ట్ రాకేష్ ఉంటే అసలు అమ్మ ఆపరేటివ్ ట్రాంబులెన్స్ ఏమన్నాం అసలు వాడు వచ్చే లోపల మళ్ళీ చెప్తే వద్దంటారని చెప్పేసి నేను ఇచ్చేసాను డైరెక్టర్ ప్లేస్. క్లియర్ కట్ గా ఎల్బీ డైలటేషన్ ఉంది, నార్మల్ అయిపోయాడు. 99% I'm thinking it is not because of bone syndrome, it is because of pulmonary embolism. Is misleading అనుకుంటున్నాను నేను. That's my perception, Srikanth Raman Prasad. Because immobilization for 3 days is rarely causing the people. Male or female?
ఫీమేల్ సార్.
Age
60 to 65 between sir.
Is she diabetic and hypertensive?
No sir, not a diabetic, not a hypertensive sir. She is asthmatic sir.
So Chaitanya, asthmatic is not prothrombotic state kada?
No sir.
So is there any, because most of the people I've seen very actively working, is she is very working lady?
No sir, she was old. She used to stay in home only, just fell from steps sir.
Sir, I'm very sorry, I missed the starting part. What was the surgery, sir?
Ma'am, it was hemiarthroplasty madam, cemented hemiarthroplasty.
Okay, cemented hemiarthroplasty. How many minutes after the cement placement did it happen, sir? Like we
Ma'am,
wait
2 to
till
3 minutes madam.
2 to 3 minutes of cement placement.
Yes ma'am.
Okay. So she was given spinal, sir?
Yes ma'am, spinal only.
Okay. So after giving spinal, were there any like issues of hypotension or anything, sir?
No ma'am. transient due to spinal decreased to around 20 mm of edges, madam.
Normally, I don't blame them. Most of the times, once they give spinal, very difficult to stay inside because there are many cases, many OTs will be running. Am I right, Jagadish?
Yes, sir. Yes, sir.
So you might have. Are you sure that? I mean, what I mean to say that every 5 minutes there is a monitor blood pressure. No, first 15 minutes or 20 minutes. So can we know
Every
before
3 minutes.
putting spinal what is a BP? Do you have the chart of that monitor?
We don't have charts, sir. We just write that in our case sheets only, sir.
No,
There is no.
normally monitor will have. You can check. No, last 24 hours analysis can be done. No.
Yes, sir. Yes, sir.
That chart can be taken. No photographs. Not now. I'm telling you normally.
Yes, sir.
Anytime suddenly hypotension happens, everybody says just now it was normal before. So for that we need to check last every 3 minutes BP or 5 minutes BP. You check it, then show it. Then it will become different. No.
Yes, sir. Yes, sir.
You declare the patient in the OT or you declare the patient post-op?
No, sir. We shifted the patient to SICU, sir. There we declare, sir.
Fine. Yeah.
Jagdish sir, so post this incident, were there any like protocols developed to prevent further incidents?
Madam, we were preloading the patient, madam, from after that case. For the previous case, which was from after that case, we have done 4 to 5 cases, madam, in arthroplasty. For every case, we preloaded the patient, madam. And before cementation, we gave 100% oxygen. And we gave hydrocortisone injection also, madam.
How much, sir? 100 or 200?
100, madam. 100.
Okay. So before cement placement.
Before cementation.
These three were the protocols.
Yes, madam.
Any
I
case,
think-
first we have to stay in the OT. That is the first dictum.
I think
Until
co-loading
complete
would.
the case.
Madam, pardon, madam.
Not only this case, any case, when you are giving the spinal, we have to stay and see the patient and monitor every 5 minutes. Normally what happened, we are giving spinal and check the level, and after that we are going another OT. We are not staying. That means we are not monitoring properly. That is the first issue.
Okay, madam.
Jagdish sir, I think preload and co-load, I think co-loading would be sufficient because in all cases, especially in like these cases, we would get geriatric patients for whom
Yes, ma'am.
we
Yes.
cannot preload. So I think co-loading would be better. And 100% oxygen you would give at the time of cement implantation, or
Just before they are starting cement implantation, we were giving, sir, madam.
will that be any useful, sir? I mean, I am just curious. I'm not questioning. I mean,
Maybe, madam, we think that pulmonary vasodilatation
అంటే
will
ఏంటి
present
ఉద్దేశం ఏంటి చైతన్య నువ్వు చెప్పేది?
అంటే 100% ఆక్సిజన్ ఆ సిమెంట్ ఇంప్లాంట్ చేసే టైంలో
అలా కాదమ్మా, నేను ఒకటే అడుగుతున్నాను. సిమెంట్ పెట్టిన తర్వాత 3 minutes లో వచ్చిందంటే సిండ్రోమ్ అని అడుగుతున్నాను. ఈజ్ ఇట్ కమ్స్ విత్ ఇన్ 3 minutes? అది నేను అడిగేది. ఐ డోంట్ నో, ఐమ్ జస్ట్ ఆస్కింగ్. జగదీష్, మామూలుగా 3 నిమిషాలు వచ్చేస్తుందా?
ఆ పేషెంట్ యాక్చువల్ గా it takes around, when the cement solidifies, when it generates heat, that time it will occur, sir. Maybe it takes around 3 to 5 minutes, sir.
అని అందుకే అడుగుతున్నాను. అందుకోసమే నేను నా డౌట్ ఎక్స్ప్రెస్ చేస్తున్నాను. దట్ ఈస్
Yes, sir.
బికాస్ ఆఫ్ పల్మనరీ ఎంబాలిజం అని అనుకుంటున్నాను. అందుకని అడుగుతున్నాను అంతే, అంతకంటే ఏం లేదు.
Okay, sir. Okay, sir.
సార్ సిమెంటింగ్ అంటే ఇమీడియట్ గా వచ్చేస్తుంది సార్.
రాదమ్మా, ఇమీడియట్ గా రాదమ్మా, కొంచెం టైం పడుతుంది. అంటే నువ్వు ముందుగా ప్రీలోడ్ చేస్తావు కదా సిమెంట్ వేసేటప్పుడు.
అంటే ఈ పేషెంట్ బెడ్ రిడన్ డ్యూరింగ్ పొజిషన్ టైంలోని పల్మనరీ ఐ మీన్ ఎంబాలిజం
బెడ్ కాదు కదా, బెడ్ కాదు కదా,
అంటే ఫ్రాక్చర్ అయిన వెంటనే తీసుకెళ్ళిపోలేదు కదా సార్.
It took 3 days, madam, for RX approval. It took around 3
sir,
days.
3 days ante chalu kada.
అంటే ఆమె బెడ్ రిడన్ ఎందుకు అనుకుంటున్నారు? అంటే 3 రోజులు బాగానే ఉంది కదా.
She was fine, sir. For 3 days OT లోకి తీసుకొచ్చినందుకు కూడా she was fine, sir.
అనురాధ బెడ్ రిడన్ అంటుంది, అందుకని అడుగుతున్నా.
సో బెడ్ రిడన్ అంటే ఫ్రాక్చర్ అయిన తర్వాత 3 days ఆన్ ది బెడ్ ఫర్ క్లియరెన్స్ ఆఫ్ ఆరోగ్యశ్రీ. సో 3 days లో షీ ఈస్ నాట్ ఆన్ క్లెక్సేన్.
ఇమ్మొబిలైజేషన్ ఫర్ 3 days అనా?
అది నెక్స్ట్ అంటే నార్మల్ లెగ్ మూవ్మెంట్ చేయొచ్చు, కానీ ఈ లెగ్ మూవ్మెంట్ అవ్వద్దు కదా, పూర్తిగా అది స్టాప్ చేసేస్తారు. సో స్పైనల్ ఆఫ్టర్ స్పైనల్ ఏంటి వాసోడైలటేషన్ ఇవన్నీ వల్ల నెక్స్ట్ పొజిషనింగ్ టైంలో అది ఒక్కసారి పల్మనరీ ఎంబాలిజం వచ్చేస్తుంది.
So maybe a protocol we can also include giving this either Clexane or anything.
చైతన్య ఆల్రెడీ ప్రోటోకాల్ లో అవి క్లెక్సేన్ అవన్నీ యాడ్ చేసుకోవాలి.
Sir,
అది మనము అంటే when you are doing the PAC you have to write the Clexane is there or not, patient history అవన్నీ మనం చూసుకోవాలి. ప్రోటోకాల్ ఆల్రెడీ ఉంటాయి, మనం ఫాలో అవ్వాలి అంతే.
నార్మల్ గా సర్జన్ ఫ్లెక్సిన్ ఇవ్వడానికి భయపడతాడు మోస్ట్ ఆఫ్ ద టైమ్స్. అది చెప్తే ఇంతమంది ఇలాగే జరిగింది, 2-3 కేసులు జరిగింది ఇక్కడ, అందుకని అడుగుతున్నాను. మోస్ట్ ప్రాబ్లమ్ ఐఎమ్ నాట్ ఫీలింగ్ ఇట్ ఇస్ బోన్ సిమెంట్ సిండ్రోమ్, ఐఎమ్ ఫీలింగ్ ఇట్ ఇస్ దిస్ వన్.
సార్ నేను సర్జన్ తో కూడా మాట్లాడాను. సార్ క్లెక్సన్ పెట్టుకోవచ్చు కదా అట్ ది టైమ్ ఆఫ్ అడ్మిషన్ అంటే, క్లెక్సన్ వల్ల కాంప్లికేషన్స్ వస్తే ఎవరు రెస్పాన్స్ అండి, అప్పుడు మేము ఏం మాట్లాడతాము, ఎలా పెడతాము అనేసి అన్నారు.
What, Dr. Manjula, you have not seen any complication of bone cement syndrome?
Sir, good morning, sir. Sir, good morning, sir.
Good morning.
Sir, actually, I have not seen any lethal cases like this, sir. But post-operatively, I have seen patients, if timely management is there, we can recover the patients if it is because of thromboembolism. Even after 5 times of CPR, we have recovered the patient after thrombolizing.
Good morning. So they are pulmonary embolism.
If it is because of thromboembolism, so pulmonary thromboembolism. Sir, అది surgical ICU చూసారు కదా sir.
I mean, like, even if it is PE, it is due to this also, sir. So ultimately, the thing that is happening in bone cement implantation is a migration of that embolic particles. So that will go to lungs only most commonly. PE due to BC.
If we recognize, I think we can treat the patients.
When you are recognized also, immediately you have to think, call the cardiologist, or otherwise you have to do echo and diagnose the PE and counseling the attendants, because that thrombolysis drug cost is 35 or 30,000. If Arogyasri attendants also not accepting.
Yeah, that is what everything is in our way, then we can save the patient. That's all. A cardiologist, echo, thrombolysis, everything should be in our way. Then only we can save the patient.
At the time of admission, cardiologist done echo. That time, patient echo is normal. So after spinal, patient developed massive pulmonary embolism. Oh, that time we did echo. So total RA is a total RA completed embolism. That time is there. So only 2 days history. And I mean, a patient is 2 days on bed. So patient not on Clexane.
Somehow
was
I am
planned,
thinking it is
Anuradha, for
because
that?
pulmonary embolism only. It is not because of bone cement. Is my opinion. My opinion.
Sir, అంటే we do in this particular case we don't see the two as separate phenomenon is my opinion, sir. The PE basically happening because of the bone cement implantation. అంటే అదర్వైజ్ అక్కడ కాజ్ ఏం లేదు కదా సార్ పేషెంట్ కి ఎస్పెషల్లీ అట్ దట్ పర్టికులర్ టైమ్ ఆఫ్ బోన్ సిమెంట్ ఇంప్లాంటేషన్. So BCIS we have
any person whoever is immobilization for more than 3 days, not being on Clexane, not being on heparin, likely to get a PE, and which is sudden. Sudden deaths are mainly because of PE. If it is a bone cement syndrome, also it cannot be sudden.
No, sir. I
mean, not because of
what Srikanth sir is saying is both are, I mean, like a particular case law, they are overlapped. Even BCS,
we don't see them as separate and
రెండు separate entity లాగా కాకుండా this could have presented as P అని అంటున్నారు సార్.
Basically BCIS ki we those two theories sir, pathogenesis lo embolic phenomenon okati, multimodal phenomenon okati. Multimodal means this complement activation and all. So akkada we can in a simple words we can say it has a mechanical and chemical. So mechanical concept ekkada ostundante we ream the bone, we expose the medullary cavity and we fill the cement in. Exothermic reaction valla adi konta expand avutundi, dani valla pressure vastundi, and we have the marrow elements over there, fat globules over there, along with that cement air and all these platelet aggregates and fibrin, all these things will cause the embolization, sir. So the next chemical theory what people talk is about the PMMA material. PMMA material, polymethyl methacrylate, is known to cause complement activation, C3A, C5A. So because of that, histamine release and anaphylactic reaction, and as BSIS and anaphylactic reaction share most of the clinical phenomenon. So these two are the theories proposed for the pathogenesis of BCIS, bone cement implantation. So mechanical theory and chemical theory. So due to the pressure and so PE, even if it occurs, I think and it cannot coincide so dramatically to that exact point of time, yes, immediately like 2 to 3 minutes of bone cement implantation. So the PE has occurred, but mostly I think it's due to the bone cement implantation. We don't see in this particular case as separate entities. That's my point.
I'm not worried about what is the reason. I'm worried about logic thinking about, like, for example, you told two things. One is a mechanical, one is a complementary, right?
Yes, sir.
In a complementary or anaphylactic shock also, very fastly patient will die. If it is anaphylactic
in
shock,
either case,
then you just have to put a adrenaline injection is sufficient to improve. If it is not a anaphylactic reaction and if it is because of the PE, then 2-3 types of this one.
Sir, mute అయిపోయారు.
కాదు సార్, ఇప్పుడు నేను అడిగేది అంటే బ్లడ్ క్లాట్ అయింది అనుకోండి, పల్మనరీ ఎంబాలిజం అనుకోండి, థ్రాంబులైజ్ చేసి ఇంప్రూవ్ చేయొచ్చు. అదే మీరు అన్నట్టుగా బోన్ మ్యారోనో లేకపోతే ఫ్లాట్ క్లాట్ అయింది అనుకోండి, మీరు పల్మనరీ థ్రాంబోఎంబోలిజం పనిచేయదు కదా. అండ్ అలాగే మీరు అనఫిలాక్టిక్ అనుకోండి, అది పనిచేయదు కదా. బికాస్ వీ నీడ్ టు అండర్స్టాండ్ ద డయాగ్నోసిస్. యాజ్ యూ సెడ్ బోత్ ఆర్ కరెక్ట్, మెకానికల్ ఆర్ అనఫిలాక్టిక్. అనఫిలాక్టిక్ అయితే ట్రీట్మెంట్ మారిపోతుంది. అండ్ థ్రాంబోలైస్ లో కూడా మనం ఇప్పుడు అదే పిఈ అనుకోండి, ఇఫ్ యూ డయాగ్నోస్ త్రూ ద ఈకో అండ్ సే ఇట్ ఈస్ బికాస్ దిస్ అండ్ immediately one trajectory place, or as Manjula said, even if you do continuously 5 times of CPR also they will survive, because our continuation of action will continue. If the patient is registered, you can do 2 to 3 hours of CPR till he recovers once you diagnose. The problem comes the clear-cut diagnosis at the time.
Yes, sir. This is where the use of advanced techniques or technology what we have comes into place. Sir. Like a TE, transcatheter echocardiography, we can diagnose PE, and also like in-house CT, like you mentioned, GMR care is having. Maybe in that scenario, they
No,
might
in-house never go for PE. This one you have to suspect unte diagnose chesi ichchedame tappa man dani gurinchi alochinkudadu. Because arrest ayinappudu most of the times there was a intraoperative PE, and if you see Jekina Srinivas 2 cases, Manimalara valla Viyapurale, she was also an orthopedic surgery, post-op PE వచ్చింది. CPR చేస్తూ while doing CPR you do the echo and do the thrombolysis and patient survived. See, I have a very good experience of intra CPR identification of PE, because that's the only thing which is reversible. Now 5H5T lo అది important kada.
I do understand, sir, but again, when we are taking an intraoperative scenario, mali thrombolysis, how safe it is with an open wound, another no doubt, sir. We just suspect.
Because life is more important than the bleeding.
That will also cause life loss, sir.
This is more important than that.
I agree with Mohan sir on this, sir.
Because life is more important than the bleeding. Because any surgery, intra-op also we are supposed to give. You should not even think about second thought should not be there. First give the drug, then decide about what to be done. It is a protocol. Manu agree adu nenu cheppedi. It's not that we agree or we don't agree. It's a protocol.
Anything more to add, sir? It's 9 o'clock. Round to such, sir, madam.
And sir?
Actually, what I wanted to say is, when we had one patient to be discharged, just night before or early morning, patient we got a code blue, and the CPR was started and everything was okay. But only thing is that as soon as we were doing CPR, the patient he was opening his eyes, and after we stopped CPR, again to fall in the BP, and again he used to become unconscious. Like that, it happened for more than 1 or 2 hours. Meanwhile, the cardiologist also came, and then we had to the 2D echo was done, which was showing RV dilatation, but not significant. ECG was showing that typical sign of pulmonary embolism, that is Q3, T3, something like that, S3, Q3, something like that. And then we had to rush the patient for HRCT, and then which was showing not a segment, it was showing the segmental pulmonary embolism. So the patient was thrombolized. I think the second day or third day patient was discharged. It's like, we were also surprised to see that even after 7, I think more than 7, 8 times we continued with the CPR. Even after vasopressor, the BP was not maintained. So only thing is that I think even I faced the similar problems, like, the patient had some debridement on the foot. After 4 or 5 years about to be discharged, they will have all this pulmonary embolism, maybe because of immobilization and not taking adequate dehydration, and everything contributed for that. So early diagnosis and timely management helps.
Yes, ma'am. Even what I was saying is, without confirmation, can we give thrombolytic in the operation theater? That's what my point is when I'm speaking.
No, but we have nowadays echo, ECG, everything. We have to
That
do till
point I
that.
want
We
to
have to
emphasize, ma'am.
support the patient. Yeah, we have to support with continuous cardiac compression and vasopressor support.
Yeah, if we have the diagnosis, I mean, like empirically suspecting a PE and giving a thrombolytic in OT,
That is very risky because the patient is already on incision and everything. Or a wound is open. I think that is more riskier than.
That's exactly my point.
Or
If
at least we
patient
can.
on PE, brady, hypotension, and sudden unconscious. I think in cement related means maybe patient is conscious.
Maybe there will be tachycardia and hypotension.
Suddenly patient is talking and suddenly gone to unconscious means that is definitely PE.
Okay, man. Thank you. Thank you,
Yeah,
Jagdish.
okay then. Thank you,
Thank you,
Jagdish.
Jagdish. Thank you, Jagdish.